Hey everyone, and welcome to the final session of our Human Performance Series. Today we have Dr. Jenna Tosto. So we will get into a great session on concussions. Now I hear that she's a concussion guru, so I'm excited to hear about all these things that has to do with the brain functionality. I personally work close to the brain banking, so I get to see live brains, see how they cut up the samples, how they preserve them, how they freeze them. So I'm excited to hear how concussions work, because the brain is a muscle, which a lot of people don't associate with. And just like a muscle, you got to work it out. And if you don't work it out, there's a good chance that that muscle can deteriorate over time. It can become not useful over time. So we're going to jump right into it. So I will throw the ball to you. You can give us a brief introduction on how did you get started, especially if you played any sports. Did you see yourself in this role? How did you get here? And about your career path and any interesting presentations you have, we welcome. So thank you, and the floor is yours.
Awesome. Thank you so much for the warm welcome, Anthony. This is exciting. I'm super happy to be here. Like Anthony said, my name is Dr. Jenna Tosto-Mancuso. I am a physical therapist at the Abilities Research Center here at Mount Sinai. And my area of clinical and research practice and expertise is in neurorehab. I do have a special interest in concussion, so I'm definitely excited to share my knowledge and share what I've learned so far. Concussion is a really interesting area, both for us in clinical practice, but just in general, as we start to understand how the brain works. Admittedly, the past 5 to 10 years have been a boom in concussion research. Our knowledge about concussions, how they happen, why it happens, and how we can help individuals after a concussion continues and has grown drastically. So I'm really excited to share that with you guys today. A little bit about my own career path and how I got here. So prior to becoming a physical therapist and working at Mount Sinai, I started my career in research. And I actually spent quite a bit of time working for the Department of Veterans Affairs, studying concussion in our service members, servicemen and women in the Army, the military, et cetera. And so that was a really cool place to start learning about concussion, because concussions sustained in the military are slightly different, but really have a lot of similarities to concussions that we see in sports. And so it's been a really cool segue for me in my career, especially as I now get into neurorehab and see different types of brain injuries across the spectrum. And so I'm really excited to share with you guys today. I am going to pull my slide deck up over here and we can get started. Okay, just give me a quick second to do a share screen. Okay. Let's just make sure we can see it. Okay, just want to confirm with a thumbs up. Can you see my slide deck over here?
Yes, I can see it.
Okay, fantastic. So we are ready to go. So again, today's theme will be cutting edge concussion care. To get started, just a little lay of the land. So we'll talk a little bit about what is a concussion, what causes a concussion, what are some of the signs and symptoms of a concussion, some red flags we look out for, what is the police safety program at Mount Sinai, and then what is concussion rehab in and of itself. And so just to kind of set the stage, there are an average of 3 million sports concussions reported every year. An average of 2 in 10 high school athletes will sustain a concussion. So those numbers are pretty significant. When we think about what a concussion is, we really like to consider the concussion a type of brain injury that is usually the result of a rapid acceleration to deceleration of the head or neck. And so this little video here I like a lot. This was put out by CDC.
Type of traumatic brain injury, or TBI, caused by a bump, blow, or jolt to the head, or by a hit to the body that causes your head and brain to move rapidly back and forth.
So as you can see, that really is a demonstration of how concussion mechanisms most commonly occur. And so again, that is largely related to that rapid acceleration, deceleration of the head or neck. Common mechanisms in sports can be a direct hit to the head, so player to player, player to ground, player to ball. Also, when we think about sports mechanisms for concussion, a lot of times it is not just that blunt force to the head, but rather the hit and then the subsequent movement of the head or neck that can result in a concussion. And like we saw in that video just now, right, there is quite a bit of movement of the brain within your head. So it's not that it is a stagnant thing that doesn't move. As your head moves, your brain can move with it. And so that is the most common mechanism we see in sports concussions. When we think about other instances of concussion, we sometimes see it in individuals after a fall or just a random miscellaneous accident. Someone gets hit in the head while doing housework or hits their head while doing something. In our military population, we see concussions after what's called blast exposure or exposure to a very big change in air pressure waves after a bomb goes off. And so the mechanism of concussion is really, really quite interesting at that. So when we see, for the purposes of today's talk, we'll be talking mostly on sports concussions. And so there are three primary areas where assessment might take place for an individual after a concussion. And so the first one being an on-field assessment. Usually it's completed by a medic, an athletic trainer, or a coach. Really what we're looking for in this is a gross neurological assessment, meaning we look to see, has the person lost consciousness, right? That usually tells us it might be a bit more of a severe injury. If the person is still conscious, are they aware of where they are? Are they aware of what's going on? Do they show anything like a red flag, something that might make us think a really more serious type of head injury has happened or any type of other injury has happened? One of the most common tools that we use is called the SCAT-5. And the SCAT is the Sports Concussion Assessment Tool. And really what that aims to do is to look at cognitive function, executive function. It aims to have a quick balance screening, right? These are all really good indicators for us if someone's had a concussion and just how severe it is. Another place for assessment might be the emergency room. So that can be for a player who was assessed on the field, deemed to have a concussion warranting emergency medical care, or perhaps for someone who sustained a concussion in another venue and self-presented to the emergency room. And so a lot of times we will make the send off to the emergency room if someone is having a change in neurological status, if we're worried for a red flag, if we think that they need advanced medical attention. And this is really the base place for that individual with a concussion to start getting medical care. In the emergency room, there are a number of different providers who might meet with a patient. That can include anything from a physician assistant, a resident, a nurse practitioner, and in some states, physical therapists. And lastly, we look at the clinical assessment, meaning going to the physician's office or to a doctor's office, if you will. And usually that assessment is most indicated for prolonged symptoms, so symptoms that are not getting better. And we'll talk a little bit about post-concussive syndrome in a few slides over. Additionally, the clinical assessment is looking to try and put a name or more of a concrete understanding to the type of phenotype or clinical presentation of the concussion. And so the clinical assessment can be done by a physical therapist, a physiatrist, sports medicine doctor, et cetera. So some of the primary symptoms we see in concussion, we jumped ahead a little bit there. Some of the really primary symptoms we see in concussion largely immediately after the injury include things like headache, dizziness or nausea, fatigue or change in mood. So a lot of times we see increased anxiety, we see just general irritability, different changes in focus and attention. So really having a difficult time paying attention, maintaining attention, dividing attention. Light or sound sensitivity, so bright lights can feel really uncomfortable. Sound can feel really uncomfortable. Those are some of the primary ones that we see early on, and the ones that we really want to keep our fingers on and a pulse on as the patient is starting to present days to weeks after the initial concussion to make sure that they are indeed on the road to recovery. And so like I had mentioned earlier, we do see what are called concussion phenotypes or different kind of hallmark cases of concussion. And we'll talk really briefly through each of these different types of phenotypes. So vestibular dominant cases are generally cases of individuals after a concussion who present with vestibular symptoms. So that might include things like vertigo, dizziness, something called BPPV, benign paroxysmal positional vertigo, which is the result of changes to that vestibular system after a hit to the head. And really vestibular dominant is something that is largely managed by physical therapists. So it is something that I see really quite often after concussion. Other types of phenotypes, oculomotor dominant, meaning optic or ocular dominant. So people have changes in vision and visual motion or movement of their eyes after a concussion. Oftentimes this can result in difficulty with reading, difficulty with focusing, difficulty with driving. And so definitely we want to make that assessment pretty early on and can indeed refer over to things like vision therapy to improve the movement of the eyes, as well as the just general visual processing. Other things we look at are cognitive or fatigue dominant. And this is a really, really big one that we keep our eyes out for, particularly in our student athletes who sustain a concussion, largely as this can be one of the really, really limiting symptoms, as well as the one that can linger around and start to develop into what we call post-concussive syndrome. And so getting an idea of what an individual's pre-injury cognitive status was. So really, do they have any changes in cognitive thinking processes, in learning, or any types of learning disabilities? And making sure that we track this as we move forward, as it's really going to be important for return to learn in addition to return to play. And similar to that fatigue dominant, where the fatigue component, or just feeling really tired out of proportion to exertion, out of proportion to any type of task that might elicit fatigue, is really, again, another primary thing we look for. Affect dysfunction or affective dysfunction dominant looks at mood changes. And so it's not uncommon in concussion for patients to feel really irritable. So feeling really just generally frustrated, having what we consider to be a low frustration tolerance, meaning the everyday nuances that you and I would normally just kind of push through and process through can really, really be upsetting and frustrating to someone with an affect change. And this can be another really limiting symptom as concussions progress. Cervical dominant being neck. So like we talked really early on, right? The mechanism of injury for a concussion, particularly in sports, is a rapid acceleration, deceleration of the head and neck, right? Your head moves by virtue of your neck moving as well. And so that cervical dominant, that can mean sustained neck pain, like a whiplash type injury. That can go hand in hand with our next little category of migraine headache dominant, in that headaches can originate from neck pain or neck dysfunction. And really that can be, again, the underlying cause of some of the other symptoms, or go hand in hand with some of the other symptoms. But especially in our sports concussion population, this is something that we keep an eye out for. Migraine and headache dominant, again, can be caused by cervical changes, but also from changes in the brain in and of itself. The research is continually ongoing into migraine, even non-concussion based migraines. It's something that the medical community is still trying to grapple with and start to understand how we can help with. Migraine or headache dominant concussion symptoms can largely be related to changes in hormones and what's considered neurometabolic cascading, or changes in brain-based metabolism immediately after the concussion and thereby after. And so it's something that, again, we want to keep our eyes on. Cardiovascular autonomic dominant. So the autonomic nervous system is a branch of the nervous system that is responsible for what we consider sympathetic and parasympathetic control. Sympathetic control being your fight or flight response, parasympathetic being your rest and digest response. And so after a concussion, this system can be dysfunctional. And usually what that presents as is decreased exercise tolerance, decreased activity tolerance, meaning patients start to get a lot of symptoms as they exert themselves. It could also result in changes in blood pressure and heart rate with positional changes. And so cardiovascular autonomic dominant types definitely have a unique presentation, and one that we have very specific exercises or rehabilitation techniques for. And lastly, light or sound sensitivity is exactly as it sounds, just really, really hypersensitive to light. And so that can be both overhead lights that are really, really bright, kind of like those really bright LED lights, sound sensitivity, any type of sound. It doesn't always have to be loud sounds. It can just be any type of sound disturbance. And so those are the general presentations that we see with concussion. A really important thing to distinguish when we talk about concussion are some of the long-term effects or potential, I should say, long-term consequences of the initial concussion, right? So if we think of concussion as one primary injury, one primary event categorized by that change or mild traumatic brain injury, if you will, two primary things that can potentially develop. Number one being post-concussive syndrome. And so post-concussive syndrome is defined as long-lasting concussion symptoms outside of the normal standard recovery. And so in a concussion that is not post-concussive syndrome, but typical injury, we expect symptoms to start to improve within 21 days, if not start to improve, be on the road to almost fully improving or remediated within 21 days. For an individual whose symptoms continue to go on past that 21 days and potentially get worse, that's where we start to see post-concussive syndrome. And typically in my practice, I do see quite a lot of post-concussive syndrome. Post-concussive syndrome in the literature is suggested to be mitigated to some extent with early rehabilitation and really, really keen attention to immediate post-recovery. We're jumping around a little bit there. And so really keeping our eyes out for those initial symptoms, like I had just demonstrated in the phenotype category, really helps us to identify how we can start to address and both medically and rehabilitate individuals immediately after their concussion to avoid the development of post-concussive syndrome. Now, a more severe presentation is called second impact syndrome. And second impact syndrome is really the bread and butter as to why we want to be extremely conscientious about return to play and really return to activity protocols for anyone who has sustained a concussion, but especially our athletes. And so second impact syndrome is a more severe sequela that results from a secondary concussion prior to resolution of immediate concussion symptoms. And so really, if we think about that player who, you know, as colloquially said, it takes a hit or gets a concussion and is not properly diagnosed or not properly sidelined, that player going back into the game, sustaining another concussion immediately within the first few weeks after a concussion, really, really can be a medical emergency and detrimental. So we want to make sure that as we talked earlier, on-field assessment, rehabilitation or medical management and medical care, we want to make sure that we're not putting our players in too soon to make sure we're keeping them as healthy as possible. And so when we think about how exactly do we do this, right? So the first 48 hours, really this is the peak of concussion symptoms in most cases. The recommendation is symptom limited activity. So prior, and by prior, I mean 5 to 10 years, admittedly, even in my time since starting to get into concussion work, this recommendation has changed. It used to be to have patients sit in a dark room, not to fall asleep, not to really do much of anything, quote unquote, until their symptoms resolved. And sometimes this was for weeks. And really what we've learned as a medical community more recently is that that's actually not really the most helpful thing for a patient to do. What's more effective is to go with a symptom limited approach. And so really letting a patient's symptoms guide how much they do. Usually we'll recommend more cognitive based rest. Additionally, screen time, so computers, cell phones, that sort of thing, can be very provocative to concussion symptoms. So we recommend limiting those very early on as to not exacerbate symptoms, and just letting the patient rest as comfortably as they can in the first 48 hours with supervision of a caregiver or someone who can be there should their symptoms escalate and require more management. And so that's really the earlier stages. And then as we get into things like return to learn or return to play, the sooner that we can get patients to care that facilitates return to learn, return to play, or just general rehabilitation, the more likely we are to see improved recovery and decrease the likelihood of developing post-concussive syndrome. And so for our purposes today, again, because we're talking student athletes, return to learn is a really, really important program or really important protocol for us to consider. And this goes across the boards, whether this is an elementary school student who sustained a concussion or a college level athlete. All of our return to learn should be symptom titrated with the accommodations provided as needed. And so accommodations might include things like having the student take brain breaks for persistent symptoms. And so by brain break, I mean, maybe they can tolerate being in class for an hour, and then we slowly work our way up to 2 hours, slowly work our way up to a half day, slowly work our way up to the full day. Thinking about other accommodations might be receiving the notes ahead of time. So if we have a patient who is struggling with cognitive changes or fatigue or affect disorders, having their school notes given to them ahead of time, or having a classmate provide written notes just to help alleviate some of that additional cognitive and physical burden is really quite helpful for symptom titrated return. And the idea being that we slowly but surely get students back into the classroom. Previous recommendations used to look like holding students out of class indefinitely, or the contrary, failing to acknowledge that there actually was a persistent symptom and really just throwing them in a little too soon. And so structuring out return to learn is really, really helpful. And similarly, return to play. So the recommendation right now by CDC is generally 100% symptom-free at rest, 100% symptom-free with normal mental activity, 100% symptom-free with exercise for return to learn. Students should be fully back in school with no medications or symptoms for symptoms. And so this is quite stringent in an attempt to make sure that we're not putting our students at risk for second impact syndrome or for post-concussive syndrome. So just really not giving those symptoms enough time to be remediated with rehabilitation care. And so return to play protocols are generally very formal, especially at larger institutions, but can be a little bit informal or less structured, depending on the setting for which the student or person is trying to get back to play. And so my return to play protocols vary largely based on the symptoms that I'm seeing. Some of the more common ways that I work to structure return to play protocols, especially with this graded symptom titrated return to activity, depends on what I'm seeing. So if I have a patient who is perhaps demonstrating more of those autonomic dysfunction symptoms, or they're demonstrating general symptoms of balance, activity intolerance, fatigue, I may go with something like the Buffalo Concussion Protocol, which is a graded aerobic exercise protocol that is really symptom mediated. So we start getting our players slowly but surely reacclimated to aerobic exercise, or exercise that gets their heart rate going. Per the name, the Buffalo Concussion Protocol is on a treadmill. So we work in intervals to build back endurance, build back tolerance, and build back autonomic tone. So that's one of the really common ones that I do quite often. Other things might be the vestibular rehab for some of those dizziness and vertigo signs. So again, that BPPV, benign paroxysmal positional vertigo. Things like habituation or adaptation exercises, which aim to help upregulate that vestibular system, meaning make it function a little bit more strongly. trying to address those symptoms, things like dizziness or instability. And lastly, things like balance training. So getting patients back up, right? It goes hand in hand with graded aerobic exercise. It definitely works on improving patients' ability to respond to where they are in space, react more quickly, things of that nature. And so those are some of the more common interventions that we use. And lastly, at Mount Sinai, we have a new concussion program that is developed out of the Charles Lazarus Children's Ability Center at Union Square under the leadership of Dr. David Putrino, who I think you guys had a chance to meet more recently. And so this is just an example of one of our rehabilitation spaces that uses virtual reality and biophilic space, meaning really patient-centered, really relaxing environments to create rehab spaces that foster recovery and encourage return to activity. So that's just a little demonstration of it. And the other thing that I'm showing over here, which I don't have the formal picture up yet, but we also have a remote patient monitoring program, which is a program that someone after a concussion can have their symptoms monitored through a phone-based application that we've developed to really ensure that they're on the road to recovery and that everything is going smoothly for them. And so I like to always introduce and thank our team. Again, I'm Jenna. Work very, very closely with Dr. David Putrino, as well as Dr. Herrera and everyone in the Department of Rehab and Human Performance. Concussion is definitely something that transcends different types of practice. And so it's a great place to be and to understand how we can help anyone after any type of sports-related concussion or head injury. And so with that, I will open the floor for some questions and see if anyone has any.
Well, thank you. Thank you so much. Yes, if anybody has any questions, you can type them in the chat or you can come off mute. If you're comfortable being on camera, the video would love to capture your face. But yes, we open it up to Q&A for anybody. Okay. So if none. So I find it interesting that when you talk about cognitive, and when I was in school, I used to always think of cognitive when I was trying to remember the word as a cog that makes everything go. That's when the brain acquires a knowledge and understanding through like your experience, your thought process, through the bodily senses. How important is it to have cognitive awareness when it comes to concussions?
That is a phenomenal question, and I love that analogy. I might steal that from you. So cognition is tremendously important. It is one of the symptoms in my experience that oftentimes gets missed. When we think about a concussion, right, we sometimes imagine that player who is stumbling off the field. So that physical manifestation, loss of balance, or that player who has really, really extreme headaches, things like that. But we oftentimes miss the idea that their cognitive status can and may be severely impacted. And so oftentimes we can pick it apart and parse it out, particularly in student athletes in the classroom, if they are a student who's doing really, really great academically, and then we see this progressive decline, or they're the student who their academic status is declining, their engagement is declining. So cognition is really important. And it can be something that, if not addressed, can result in more long-lasting problems and issues for a person after a concussion. So definitely feel that it's an important thing to understand. The literature is still evolving, and the opinion on the literature changes time and time again about the benefits of doing what's called baseline testing for cognition. So baseline testing, meaning in the beginning of a season, everyone gets tested, and then subsequently will get tested after the injury. It's definitely something that's evolving, but nevertheless, immediately after the injury, definitely something that healthcare providers want to have their eyes out for. It's something that I screen for in all of my patients, and it's something that a patient might not self-report. So if I say to someone, hey, are you having any cognitive changes? They may not report that. They may not recognize it immediately thereby after, but it's really, really important for us to keep our eyes out for. Absolutely important.
Okay. We have a question in the chat. It says, can you speak a bit on CTE?
Sure. So CTE, chronic traumatic encephalopathy, has become definitely a mainstream topic, particularly when we look at a lot of the research coming out. The NFL, the DoD, there's a really, really impressive CTE center up at Boston University. The literature coming out of there is really impressive and has been really impressive for the past 10 or so years. And so CTE is the early development of what are called neurofibrillary tangles and tau proteins. So there are two different types of molecular compounds in the brain that typically result in what's considered early onset, almost Alzheimer's-like presentation. So manifestations for CTE can look like significant cognitive changes, significant mood disorders. So a lot of times reporting people who are very easygoing and nothing really crazy will upset them, going to becoming very, very upset very, very easily, low frustration tolerance, quite a myriad of other symptoms that go along with it. And so as we, as a medical community, started to recognize the pathophysiology of CTE and how that might be affecting people, it's definitely all the more reason that concussion care and concussion assessment is taking the front stage, particularly in spaces like military theater, sports, et cetera. As far as diagnostics for CTE, we're not quite there yet. A lot of the studies in CTE are looking at post-mortem assessment. So after an individual has passed away, they can donate their brain to brain banks, which I know, Anthony, we had mentioned early on. And so this idea that the tissue and the molecular physiology of the brain can be studied thereby after to make a diagnosis for CTE. I think it's incredibly important. The literature on it and just the medical knowledge on it is really, really significant. And it's also, I think, a very large reason why we're all putting spotlight on concussion to better understand it. Again, it's a bit, concussion is unique in that it still falls under the field of brain injury, right? So when we think about brain injury, we categorize mild, moderate, severe. Concussion is considered a mild traumatic brain injury. But the pathophysiology and the biomarkers for concussion just aren't quite there. So if I were to scan someone's brain immediately after their injury, meaning I do an MRI or a CT scan, I'm not going to see anything. Versus if I have a more severe brain injury, I can actually see where the damage is. And so my instinct really is that as we continue to learn more and more about CTE, one of the big things that I know a ton of groups are looking for is what's called a biomarker, or some way that we can detect the presence of potential CTE before it really, really expands out.
Okay. Is there any other questions? I'll look in the chat and anybody could come off mute at any point. One thing I wanted to talk about was you mentioned the Alzheimer's and the way the brain deteriorates over time. When I, as an adult, I love the origin of words. So when I was trying to look up concussions, it noted that the origin is shaking or earthquake effect of the brain. So when you hear that in that context versus just saying concussion and give an explanation, when you hear like earthquake effect of how it affects the brain, how can a sports person take that phrase seriously in terms of I might be off, my signals might be off slightly, but I don't want to come out of the game? How would you explain that to an athlete on how to convey that message?
That is a phenomenal question and a conversation that I encourage anyone who is involved in sports medicine or sports in general, and this means coaches, players, athletic trainers, anyone involved. I myself have had these conversations and have hosted these talks with sports teams, even at the college level. It is a difficult conversation to have when someone is so passionate about their game. And I see this all the time for players who, especially if this is the winning game, this is the game that makes the difference in their career per se, right? There is a scout watching, or you want to make sure that your stats look great. That definition, I think, really sets in and should ring home and set in and ring a bell for players that while concussion is, like, we showed those demographics, like 3 million, it's common. It is still considered a head injury. It is still considered a brain injury. And there is the potential for long-term effects if not taken seriously. I tell all of my players, let's get this right the first time. Let's take the time that we need to make sure that the symptoms are managed, to make sure medically you're managed, so that you can make a safe return to play, so that you can have a really long, fruitful, fun career. And it's not that this now becomes this identity that will be long lasting and that you'll be dealing with for years to come. And I think the more that we understand about concussion, again, for things like changes in brain metabolism, changes in brain hormones, it's not merely I hit my head and I don't feel so great, but the term used to be like a bell ringer or a stinger, right? That puts it at a very like colloquial blase level, when it's actually a more serious event. So I think understanding that admitting you're not feeling great is important. Your medical providers are on top of it. We can tell, we're going to pull you out. And it's not because we want to be mean or we want to limit what you can do. It's because we care. And we know that if we can really address this early on, we have better chances for long-term success in the future.
Okay. If by any chance, could you explain the connection that might not be as easy to express in terms of terminology when you see former NFL players that suffer from concussions and then kind of either go suicide or some type of erratic behavior? Can you explain what is the connection between concussion, CTE, and that extreme measure of outcome?
Sure. Full disclosure, I do still think the area of research is underway. We are still trying to understand biomarkers and pure pathophysiology of concussion and post-concussive syndrome, as well as really what is the difference between a player who, full NFL career, doing fabulous, goes on to have no symptoms versus player, full NFL career, CTE. I think what's really important to understand as we learn more and more about the literature, learn more and more about the process, is that the neurometabolic processes that go on after a concussion, in my opinion, and per the literature, are likely underlying a lot of these symptom presentations or symptom developments. For an individual who has that full career, multiple concussions, a lot of times they're concussions that don't get reported. A lot of times they're that concussion, multiple concussions in the same season. And a lot of times it's post-concussive syndrome that just is not medically managed or rehabilitated appropriately. And so it's, again, a hot topic. It's something that a ton more research is needed on. But I do think it's an important thing to recognize that there is a potential for long-term consequences after a concussion, even if the initial injury did not appear to be severe.
Is it possible to misdiagnose a concussion in terms of non-athletic contact? Like, say there's a bunch of middle school or elementary schools, children running around playing, falling, and teachers are not seeing that they hit their head or bump their head slightly, and it is misdiagnosed as like a behavior thing. Is that possible?
Yeah, absolutely. I think that's absolutely possible, which is why I think that if anyone is ever suspicious for a concussion, there is absolutely no harm in accessing your healthcare providers, using resources if you have, even within the school itself, school nurses, athletic trainers, et cetera. But not all concussions are sports concussions, right? There is any rhyme or reason why it might happen. We see concussions in children who are playing, especially interestingly this winter, I saw an influx of children with concussions, particularly when we had a lot of snow from like sledding and bumping into something, or playing with friends, bumping into each other. Older adults, we see it sometimes after a fall, right? So they loss of balance, falling, home improvements, right? Someone is doing something, they hit their head. Any particular reason, a concussion can occur. And so if someone is suspicious for a concussion, seeking medical attention just to have something ruled out can be important. And as a parent, if you are suspicious that this could be related and you're not confident that it's this new onset behavioral presentation, I am a very, very big advocate for advocating. So if you're not sure about something, it doesn't hurt to get it checked.
Okay. Earlier, you mentioned something in terms of like loud explosions. how do this I guess the effects of sound waves cause concussions in folks?
Great question. Yes, so and we see this mostly in military theater, particularly individuals who are exposed to things like IEDs. Concussions, when the ones we described today, primarily looked at the mechanism of acceleration, deceleration of mechanical changes to the head or neck. But changes in sound waves and pressure waves can also cause concussion. And so how that generally works is your brain is suspended within your head. Vast changes in those types of pressures can change the brain tissue in and of itself, which thereby results in a concussion. And so while the mechanism is different, a lot of the metabolic and neurotransmitter-based changes that we see are very similar. So it's a bit of a non-traditional mechanism for concussion, but nevertheless, we definitely do still see it.
So if you can explain a little bit, what signals or aspects no longer communicate with the brain when an explosion or when a hard hit occurs?
Sure. So the miscommunication in concussion is largely rooted in this rapid change in neurotransmitters. And so neurotransmitters as well as metabolites and metabolism. And so what that generally looks like is your brain has a resting state for things like glucose and glutamate and several other neurotransmitters that are of significance. When you sustain a concussion, there is this rapid peak and rapid drop in those different types of hormones and neurotransmitters. And that rapid change changes cellular function, right? Our brain works via connectivity of neurons. And so those neurons fire by something called an action potential, and they communicate by back and forth of those action potentials. When any type of homeostasis or essentially baseline cooperativity is disrupted, there can be a disruption of that connectivity or of those neurotransmitters and action potentials. And so that mechanism in and of itself is how a concussion presents with symptoms, as opposed to if we think about something like a more direct traumatic brain injury, maybe something that has a result of like a brain bleed, where there's a direct lesion or location of injury. A concussion or a traumatic brain injury is more diffuse or global.
Okay. Is there any questions from the crowd? If not, I have one final question. Give it a second to see if there's any. Okay. So my final question is, I was watching something when I was younger, and it was explaining the brain sensitivity and where where it lives. So it's explaining the brain as being in a case, and this case cannot expand, it can't grow, that if the muscle is injured in any way from a blunt force trauma or a hit to the head, it will swell because it's an actual muscle. But because it's cased in this thing that doesn't expand with it, that's where you get a lot of pressure, and that can cause a lot of functionality because the muscle has to not only shock itself by growing and expanding from the hurt, but also having time to alleviate. But if it doesn't have a chance to expand and decrease, then you can have a lot of bad effects from it. How does that explanation of what I just said connects to a sports injury? I was just curious to know.
That's a great question. So what you're describing would be considered intracranial pressure. So you're absolutely right. The brain is something that is dynamic, but does not have the space to expand. So if, for instance, you bump your arm, right, and you have what's called a hematoma, or you get a blood collection under the skin, there is room to move a little bit. The skull being a non-flexible encasement, should there be any insult to the brain that warrants any type of swelling, we get what's called an increase in intracranial pressure. Now, we don't typically see significant changes in intracranial pressure with pure concussion. We do, however, see it quite frequently in more moderate to severe level head injuries. And so while that is something that we look for, that might be a red flag for a more severe injury. Usually when we have increases in pressure like that, we see significant worsening of concussion-based or head injury-based symptoms usually resulting in things like loss of consciousness, shutdown of vital functions, really more severe presentations. Whereas with a concussion, we don't generally see it, but it's a really important thing to understand. So if you're looking for red flags, you understand the pathophysiology of why they might be happening.
And we have a question from the crowd. It says, I had a car accident once and had a concussion. Is there anything I should do to see if the concussion has caused cognitive problems years later?
It's a great question. So we can and often see different changes after a concussion, not only immediately after, but as you say, years later. And so absolutely, it's worthwhile to be checked. Usually for cognitive symptoms, I refer to neuropsychology. That is their bread and butter. Here at Mount Sinai, we actually have a center dedicated to this. It is called the BIRC, the Brain Injury Research Center. They are incredible, and they specialize in all types of cognitive change resulting from any type of head injury, and that might include concussion. I've had the opportunity to work with them. They're fabulous, and so I always advocate for that if patients are interested in learning more about potential cognitive therapy and cognitive remediation. By all means, doesn't matter how long it's been. Let's see if we can help it.
Thank you. And I had one more question. Just popped
Sure.
into my. Is there a different way in the way that you might address the level of activity in the sport versus the injury with the player?
So return to play protocols, we definitely look to titrate. And so we take what their normal activity might be for sports training. Number one, we take that into account. We also take into account any of the protocols like we had talked about, right? Some of those Buffalo concussion protocols, or what are we seeing from a symptom presentation? And we put those together in addition to looking at the player's day-to-day life. What is their life role? What are their responsibilities, right? Returning to class, if they're living on campus, commuting, things like that. And we really try to work to titrate and structure it based individually. So it's usually a very, very individualized program, depending on the extent of their injuries, really trying to meet them where they are while slowly getting them back to where they want to be. And again, those return to play protocols are targeted to see the symptoms that they're experiencing. So from the rehab end, that's really what we're working with. And then as we start getting them back into their normal workouts, it's a very, very symptom titrated approach. So maybe they're starting with the team workout, but it's modified. And now they're doing that for half day, then they're doing it for the full day, slowly but surely getting them back.
Okay. All right. So those are all the questions I have. Is there any final words or anything that you'd like to say to the group or anybody that might be watching the video?
Absolutely. Definitely, like we had advocated for, concussion is something we want to take seriously. So if you're suspicious of it, definitely don't hesitate to report it. If you are a player, understand that staying on top of these things early is going to help in the long run. And if you're a healthcare provider, this is a really, really unique place to sit and to help with. So by all means, I encourage everyone to get in the know about concussion.
Well, thank you for your time. We enjoyed your presentation. We enjoyed the Q&A session, and we hope to have you back again to speak on behalf of SWAG and any other programs that we have coming up.
Thank you so much for having me. This was great.
Thank you for everyone that came out this Saturday. I know it's beautiful, so I want you to get back to enjoying your weekend. So we will contact everybody soon with the next calendar of events. And take care, be blessed, and see you on the next recording.
Bye, everyone.
Bye, everyone.